Hello, my name is Dave Shahian. I'm from the Massachusetts General Hospital and Harvard Medical School, and I chair the Society of Thoracic Surgeons workforce on national databases. The four of us are here today to talk about the current status of the STS National Database, but even more importantly, how we're moving the database forward so that we continue to stay in our leadership position among all specialties in medicine.
Hi, I'm Cam Wright. I'm also from the MGH in Boston, and I chair the General Thoracic Task Force for the database.
And I'm Rich Prager from the University of Michigan in Ann Arbor, Michigan, in adult cardiac surgery, and I chair the task force on the adult cardiac surgery database.
I'm Jeff Jacobs, and I'm a cardiac surgeon at All Children's Hospital and Johns Hopkins Children's Heart Surgery, and I chair the STS Congenital Heart Surgery Database Task Force.
The STS database started in the late 1980s. Its primary rationale at that time was to provide feedback to practitioners as to their relative performance. Over the last 22 years of its existence, the database has evolved into many new areas, and we are today one of the leading clinical registries in the world. But healthcare is rapidly transforming, and we need to stay ahead of that transformation. So today we'd like to talk about a number of areas that we're moving into aggressively in order to maintain our current leadership position. Consistent with what we've been doing over the past 22 years, one of still our major areas of emphasis is performance measurement. And we have developed many risk models for risk adjusting performance measures, and also an expanding portfolio of measures that are endorsed by the National Quality Forum. I thought maybe I would ask my three colleagues if they could comment on some of the measures that have been developed in their particular specialties. Cam, what's happening in general thoracic surgery?
Well, thanks, Dave. We've been in existence now for 10 years, so we're one of the infants of the STS database. And we've developed over these 10 years 5 risk models. We have 4 risk models having to do with lung cancer resection, and then one with regards to esophagectomy, all for cancer. All of these are NQF approved, and we have other NQF approved measures as well. And we've made great strides. We started very small, and we now have almost 250 participants in the general thoracic database and over 800 surgeons, and we continue to grow every year. Our next measure, important project that we're working on with Jeff's help, is public reporting. We're working on a composite measure of quality. We want to be transparent. We want to follow the lead of the adult cardiac database and put out a public measure of excellence in lung cancer surgery, and that's going to be our focus over the next 1 to 2 years.
Thanks, Cam. Rich, what's happening in adult cardiac surgery?
Well, the adult database, if I may, I would say is probably the grandfather of the databases, having started with the initial data points in 1989 with a focus on coronary artery bypass. But as our specialty has evolved, we have expanded our risk models, cover not just coronary bypass, but isolated valve procedures as well as valve and coronary procedures. The challenge to all of us is to create this database to meet all the demands that we're being asked to really stay abreast of and frankly lead. And that includes not just using the database for quality initiatives at your own hospital or in your region, but for using the data elements to create opportunities to compare treatment modalities across specialties, including cardiologic interventions compared to cardiac surgery interventions, to step into the world of healthcare economics, and frankly to continue to lead in acquiring these pieces of information for our society.
And one of the things in adult cardiac that we've done is to commit to rolling out one new performance measure for public reporting each year. So We now have about a 5-year experience with the isolated cabbage composite measure. We have just implemented the isolated aortic valve replacement composite measure. We're working on a similar measure for aortic valve replacement and coronary bypass surgery. And after that, we'll be doing isolated mitral valve repair. So we're aiming to have a whole portfolio of these composite measures so that somebody can really get a very broad perspective on a particular practice. Jeff, what's happening in congenital?
So the STS Congenital Heart Surgery Database was founded in the mid-90s under the leadership of Gus Mavroudis. Currently, the STS Congenital Heart Surgery Database represents 84% of the programs that do pediatric heart surgery in the United States. And early in the development of the STS Congenital Heart Surgery Database, it became apparent that there's tremendous variation amongst programs in case mix, with some programs having an emphasis on high complexity cases and other programs doing intermediate and lower complexity cases and sending the higher complexity cases to referral centers. And as we began developing performance measures, it became apparent that the first step was to find a way to deal with this variation in case mix. So currently, we've developed and implemented a strategy to report our outcomes in a complexity stratified manner. And we use this complexity stratification tool where we can group all of our operations into 5 different buckets of complexity. This methodology has been endorsed by the National Quality Forum and forms the basis of our outcome reporting. We've published from the STS Congenital Heart Surgery Database a portfolio of 21 quality measures stratified into structure, process, and outcomes measures according to Donna Bedian's triad. And a subset of those measures have been endorsed by the National Quality Forum. The outcomes measures are based on our complexity stratification tools that I just described. And in the future, we plan to begin to develop lesion-specific performance measures and begin to also go through the process of getting our lesion-specific performance measures endorsed by the National Quality Forum.
Thanks, Jeff. Historically, what we have done with these performance measures is to feed them back on a confidential basis to our participants. But increasingly, there is a call for transparency and accountability in medicine, and we're very proud to be really one of the very first specialties that has voluntarily undertaken a public reporting initiative. We do this both on our own website, and we have an initiative with Consumer Reports. And currently about slightly less than 50% of the participants in the STS database voluntarily put their results on one of these 2 sites. And we're encouraging, with every opportunity we can, those colleagues who are not yet doing it to do so, because we want to continue to demonstrate our society's commitment to full transparency. And this is information that is very helpful to patients as they make that very important decision about where to go for cardiac surgery. Measurement is not an end in itself. It is a means to an end, and really the end that we're all seeking is improvement in patient outcomes. Rich Prager, as chair of the Quality Initiative Task Force, can you tell us a little bit about what's going on there?
Yeah, there's a lot of energy around the concept of using this database and having it be the platform, if you will, for quality improvement initiatives at hospitals, and as a part of that, perhaps even redesigning how the information will come out in your report to make it easier for you to see, to create, if you will, a dashboard or something on the wall in your practice about what you're doing, as well as tying it in with information that we take from the database, such as glucose control or such as infections, and looking at best programs and other programs and saying there are potential improvement opportunities, and have the task force then use the database to send this really to all our members. And I failed to mention that on the adult side, about 95% of the programs in the United States that do adult cardiac surgery are in the database. So we have a rich opportunity to use the data combine it with the other people who are part of quality initiatives in their region, at their hospital, or who are actually experts on performance enhancement or learning improvement techniques to take this to their institutions.
So going forward, you see a lot more emphasis on education of our colleagues across the specialty in evidence-based best practices.
Evidence-based best practices and using the data. Really just, we have a tremendous resource, and we have to use it even with more energy, really, across the country.
As good as the STS database is, we historically have only collected information about the patient during their hospital stay or within the first 30 days after surgery. Increasingly, though, we realize that that's only part of the picture. And I wonder if Jeff, as chair of the Task Force on Linked Registry Initiatives, perhaps you could address that a little bit. And I'd like Cam then also to talk a little bit about what longitudinal follow-up might mean for the general thoracic database, because so many of your end results really in cancer surgery, for example, are long-term outcomes. So let's start with Jeff.
Well, STS has invested a huge amount of energy in developing strategies to link all three STS databases to a variety of other registries and databases that contain information not contained in the STS database. These linkage strategies allow us to do a variety of analyses that would simply not be possible with the STS database alone. One strategy that we've used is to link databases together to do comparative effectiveness research, to compare the outcomes of two different treatment strategies. Another strategy that we've used to link the databases together is to be able to use the linked data to study healthcare economics by linking clinical data in the STS database to resource utilization data in an administrative data set. And a third strategy is to use the linked data sets to help transform the STS database into a platform for longitudinal follow-up. So these linkages with administrative data sets and other clinical registries allow us to do a variety of other analyses, comparative effectiveness research, healthcare economics studies, and longitudinal follow-up. And all of these different strategies really increase the power of the STS database. And I think Cam can give some great examples about longitudinal follow-up of thoracic surgery and how that could allow not only to find out short-term outcomes, but also long-term outcomes for cancer surgery.
Cam?
Well, thanks, Jeff. Indeed, thoracic surgery has progressed to the point right now where the perioperative morbidity and mortality are quite low, and actually we have very little variation among STS surgeons who practice thoracic surgery at a very high level. But what we and more importantly the patient are very hopeful for is long-term outcome, long-term survival. Am I cured? Am I going to be with my family in 5 years? And that information we currently don't have, but we're working on obtaining it. And we can do that in one of two ways. One, we can expand our database to collect data points down the line, which we plan to do in the future. But right now, we're linking our database, as Jeff said, with the Social Security Death Master File, with CMS data, to provide that data. And in fact, we have one grant that's been approved with a couple of our member colleagues looking at that to look at lung cancer survival 5 years hence, and looking at the concept of thoracotomy versus VATS for the approach to lung cancer resection. Other areas where it would be important, for example, would be the increasing emphasis on radiosurgery and comparing clinical stage 1 lung cancer treatment with either surgery or with radiosurgery and linking up the database with CMS that way. I also want to mention MOC Part 4. American Board of Medical Specialties a number of years ago told us, the American Board of Thoracic Surgery, that we needed to do quality improvement as part of our ongoing professional obligations. And MOC Part 4 is that. And right now, if you participate in the STS database, MOC Part 4 is satisfied for the American Board of Thoracic Surgery. It's just another reason to participate in the database. David?
Thanks, Cam. Rich, one of the best examples, I think, of the value of linked registries is the ASSERT trial. Could you tell the audience a little bit about that?
I think the reality of combining data with the American College of Cardiology National Database, as well as our database, has been able to, if you will, define groups across specialties and look at outcomes across specialties, such as for triple vessel disease, the most appropriate, or the treatment that gives the best options to the patients. And I think this honestly is the future that we're talking about, and how, one, we link or create new ways to deal with data and feeding data into our systems in a shared way, so that everyone has an opportunity to look at this, and we can, if you will, define categories better, cohorts better, and honestly provide not the STS society, but American society with cleaner understandings or answers to what to do. I also think that there is an opportunity that the STS has led with people, frankly, such as yourself, in helping the country understand how we should measure quality. And isn't that part of our specialty's role, to help produce the information so we help define what quality is for what we do? And sometimes it's a little stretch for all of us to look at.
The collaboration that Rich was describing between the ACC and the STS has been very fruitful, and we hope to have a lot of similar things going forward, because there are many areas in cardiac care where there are different ways of treating the same problem. Coronary artery obstructive disease is one good example. A stent can be placed or bypasses can be done, and there are different scenarios in which one or the other may be better. And by linking the data sets together and linking them jointly to administrative data, we can actually look at the long-term outcomes of various types of treatment for specific patient subgroups. And this can be part of the informed decision-making process between a patient and their surgeon and their cardiologist. These are the short-term risks of having, for example, a stent or coronary bypass surgery. This is the likelihood that you will be alive 5 years from now with each procedure. This is the likelihood that you will have had to have another procedure, and so forth. So this sort of collaboration, I think, will be extremely important going forward. We talked a little bit about these government collaborations and use of government databases, and that's an exciting new area, I think, that we're going to be moving forward with in the STS database. I don't know, Jeff or Rich, would you like to talk a little bit about some of the collaborations that
Sure.
Are evolving?
Sure. Well, we've already talked a little bit about the ASSERT trial, which used a linkage of the STS database to the American College of Cardiology database to the database from CMS, the Center for Medicare and Medicaid. And that linkage of the STS database to Medicare data and to the ACC data can be used to perform a research engine, and this research engine can then be used to do a variety of research studies. Now, besides linking to CMS, there's a number of other governmental and non-governmental administrative data sets that we're already linked to or in the process of creating links. In the STS Congenital Heart Surgery database, we've linked our database to the Pediatric Healthcare Information System database, which is called the FIS database. And this is an administrative data set that contains huge amounts of information about medication and resource utilization. That's allowed us to do studies about pediatric heart surgery that the STS database alone simply could not do, looking at comparative effectiveness of certain medications in the perioperative period, and looking at the impact of different treatment strategies on the cost of stay in the hospital. So that's another example of linking to an administrative data set. Another example is to use governmental data sets to study longitudinal follow-up and longitudinal outcomes. And we've done a fair amount of work with the Social Security Death Master File as a tool to verify life status. Currently, we're now working with members of the federal government to try to enhance our methodology for using these data sets for longitudinal follow-up. The Social Security Death Master File currently has some limitations, and we're trying to either resuscitate the Social Security Death Master File or possibly use an alternative data source, which is called the National Death Index. And I think it's possible that either an enhanced Social Security Death Master file or a modified National Death Index could be linked to the STS database in such a way that we would have a tool to verify the life status longitudinally of all the patients who have surgery in our databases.
Rich, what about the collaboration between STS, the Food and Drug Administration, and the American College of Cardiology and Edwards Life Sciences in development of a registry for post-approval follow-up of patients that have these new transcatheter valves?
Well, and there is a registry, the TVT registry, that basically is an example of collaboration that frankly did not exist until the relationship between the two organizations really set the stage to say, let's put this all together. Let's be able to do approval mechanisms by really shared decision-making on both, from both specialties. And now, for example, the percutaneous valves are put into this registry, those that are FDA approved, and they'll continue to be followed. New, if you will, procedures or interventions or devices, I suspect now we have a mechanism to follow this for post-market approval and really follow these and help the government understands utility, potentials, options, and as new devices come, put them in the same type of scenario.
So for those that aren't involved in the rollout of new devices, these all have to receive FDA approval, but these approval processes are often based on fairly restricted populations of patients. Once these devices get rolled out into general use, then it's important to continue to follow up how the patients are doing as they reach an expanded population of patients. Let's think about a few other collaborations with the government, because we see this as a very fruitful area. The Centers for Medicare and Medicaid Services has for a number of years published the results for heart failure, pneumonia, and myocardial infarction on their website. They've always used administrative data. We have now developed relationships with CMS that we hope will lead to our clinical measures, which are widely accepted within our community and outside our community with other stakeholders. Use of our clinical measures for the hospital compare site. So we're very enthusiastic about that, and the fiscal cliff legislation that was recently enacted includes very specific language that recognizes the utility and the superiority of clinical registries and encourages their greater use. So we think we're very well positioned going forward to participate in these kinds of efforts. So I hope that you've gotten the flavor from our discussion today that the STS National Database is not just relying on its status after 22 years and treading water, but in fact we're trying to position the database and our society to continue to be the leaders in healthcare quality measurement, quality improvement, with the ultimate goal of improving the care of all our patients.